All right, good afternoon. My name is Mike Demeure. They told me I'll introduce myself, so I'm pretty new here as far as on staff. Started in May. I'll do a little background. So I'm endocrine surgery by training. I did my... Is it not working? Okay. Well, they said it would. Okay, so can you hear me better now if I'm here? Okay. So I'm an endocrine surgery training background. I did general surgery, then a fellowship in endocrine surgery. So that was University of Arizona, and then fellowship in endocrine surgery at UCSF. I went through the academic routes at the Medical College of Wisconsin, assistant professor, associate professor, then went back to University of Arizona. I was professor and chief of general surgery for a while. 2008, I moved up to Phoenix. I was with the Translational Genomics Research Institute, which was basically started by Jeff Trent, who was number 2 to Francis Collins in the Human Genome Project, with the purpose of getting genomics into the clinic and helping patients. Obviously, a big focus is cancer, but there's also neurologic diseases and as well as some metabolic diseases, childhood disorders, as far as research focus there. But ultimately, that led me to contact with Hoag, and so then working with Bert and Dory in the Cancer Center, ended up here. So maybe just as a bit of resident by hand, who feels that like they've used genomics in the clinic? And we know we have our genetic counselors here, but just anybody used genetics or genomics in your clinic at all in any way you could think of? All right, so I think we're starting to see it permeate into every field of medicine, and I'm going to highlight that, but really showing how the Cancer Center is developing some programs that hopefully will then benefit the entire community at Hoag. So today we'll just talk about what is precision medicine, this idea of using genomics to guide therapy. The 2 to 3 slide primer on genomics. Then pharmacogenetics is one area where it's being applied, and talk about an initiative there, as well as some other things that we're doing at Hoag already where genetics is involved, and how this is benefiting patients. So really the latest push has been through a couple efforts, after the Human Genome Project was done. Then we said President Obama with Biden and their moonshot really gave it the latest shot in the arm, if you will, where it said, you can match a blood transfusion to blood type, and this was very important discovery. But what if we match a cancer cure to the genetic code was just as easy? Or what if figuring out the right dose of medicine is as simple as taking a temperature? And that's the promise of precision medicine, getting the right treatment at the right time, every time to the right person. But, and that's part of why we're here. We see this is a recent editorial in JAMA. It says to leverage all these advances in precision health, non-geneticist physician must gain an adequate understanding of these emerging technologies. And this is no easy task because the technologies are complex. They're in continual, and I'll add rapid evolution. And given their newness, there's few evidence-based guidelines exist to guide prudent clinical application. I'll tell you that's one of the other impediments, other than educating ourselves in this, is the insurance companies without these guidelines and clinical efficacy paying for the use of these technologies. So we apply it, and using all these, this is precision medicine, is using the novel genomic technologies so we can very often predict disease early and then intervene either before the onset of disease and prevent it, or pick up perhaps a cancer early and then have a better outcome. We use it to maintain health. We know about the genetics of certain cardiac risk, for example. And then also getting the right treatment, as was mentioned. But the benefit of getting the right treatment is that it's more beneficial to the patient. You have reduced side effects. And I'll also argue in cancer, you have an opportunity cost if you go on a treatment that doesn't work. The cancer is just growing, the patient's getting sicker. So there's a negative to be on an ineffective treatment. And getting on the right treatment has already been shown to decrease costs. The wrong treatment is also a more expensive treatment. So when we talk about, and this comes from, I got my MBA, this is a slide from one of the books that we read for the business degree, but in terms of adopting new technologies. There is a group of people that will be over here in the innovators. They want something just because it's new. Think about the iPhone. There's a whole bunch of people that are waiting outside the door of Apple for the store to open. They don't know what it is, but it's the newest, latest thing from Apple. So they're camped out. They're going to get it because it's the newest thing. Most people fall in this group over here, which I call the early majority. We'll wait and see, but if we start seeing, oh my goodness, I can take pictures, keep all my contacts, I can make phone calls, keep my calendar and appointments. I can use it to tell me how to get to somewhere in Los Angeles, you know, because it's got a map feature. All these things make my life easier and better. I'm going to go buy one. Well, this is when it hits and Apple could be profitable. They're not going to make money on the handful of people that are waiting outside the door to buy the first new phone. So, and this going from these innovators, we call early adopters, over to the early majority, the mainstream, is when a company makes money, but it's also when the technology gets used. And to bridge that gap, people have to understand how it makes life better. And for argument for doctors, how does it help us take care of our patients better? Do we get better outcomes? Is it easier? Can we take care of patients less expensively and get better outcomes with, you know, is out. So that education process is part of what we're doing today, but also, you know, a continual effort. We also need to have data collection so that we can demonstrate we have the information and the proof that patients are doing better. And this also, at least in the cancer center, is some synergy. If we identify a gene mutation in a tumor, like example would be BRAF in a melanoma, we have drugs that can hit that gene, that mutated gene, and kill or have a better efficacy in the tumor that exhibits that mutation. So it's linked to the efforts that have been going on in the cancer center on the phase 1 or early drug development. These are drugs that aren't approved yet for use, but are undergoing clinical trials. And so this early drug development is synergistic, because if we identify gene mutations in cancer, we want to have the drugs or the agents that allow us to take advantage of that. So again, I promised a brief primer in molecular genetics and oncology. Well, when I was in medical school, which was a long time ago, there was the lac operon. So, I mean, lots happened since then. Because I've been involved in research and working on it, I've learned on the way. But to keep up, this is a rapidly evolving field. But the real basics for practical is that the DNA has the blueprint, and it's like the house. You have a blueprint for a house. If the bodies of a house is the house, the blueprint or the plans for the house are the DNA. It's present in every cell of the body. Now, if you want to build a door, there's a workman that looks at the blueprint for the door and builds it, puts it in the house. That's the RNA. That's the workman. That takes the gene and transcribes the particular gene to a protein, which is the door, the building block of the body. It may make an enzyme. It might make, a structural protein or whatever. But the RNA is what takes the information from the DNA and makes the relevant proteins. When the DNA has a mutation or this process goes awry, you can have a disease state. Now we know the environment impacts on the development of disease. Just the same, the people that smoke, well, you could have somebody that smokes all their life and doesn't develop a lung cancer, but somebody who never smoked or smoked a little bit gets a lung cancer. So clearly the environment interacts with the genetics to cause disease and ultimately. So when we talk about genomics, that is how the DNA sequences in the disease cells are studied. Genetics is the genes in every cell of our body. It's our background DNA. And now some genetics cause disease. A mutation in a germline BRCA, increased risk of breast cancer, RET, increased risk of medullary thyroid cancer, virtually 100% risk of medullary thyroid cancer. So based on genetics, we can predict the disease. But other tumors have just the mutation in the tumor. So in other words, the melanoma I mentioned as a BRAF, that's not in every cell of the body. That is a mutation that's acquired in the tumor. And so that is using genomics and gene mutations that are just present in the cancer cells. So I came to Hoag because Hoag has, we have an opportunity to take this genetics precision medicine approach and get it to patients. The leadership of the hospital wants to make this happy. They're forward thinking. They see that as getting high quality medical care to our patients in our community. They've already done a lot of work to establish the early drug development program, so we have access to new drugs. I said the mindset is to be innovative and be on the forefront of new technologies for our patients, and the community is very supportive and engaged. So either through philanthropy or the doctors are very supportive. So where are we now? I mentioned we already have I'll just say a phase 1 program with a lot of infrastructure. It's already in place. It's not mature. It's growing. We're going to have more drugs, and the menu, the repertoire of agents available to us will be increased over time. But there are doctors and staff already devoted to the effort. We've recruited a full-time molecular pathologist. We have an excellent genetics program with 2 very good genetic counselors in the Cancer Center. Based on that, for example, we've developed a new screening program for people that have increased genetic risk for pancreas cancer to put them in a screening program so we can pick up those cancers early. We know most pancreas cancers are picked up, they've already metastasized. So the goal is to pick them up early, that we enroll the patients that are at increased risk based on that. In fact, there's a Stand Up to Cancer grant that Hoag is part of to do just that. That has just been recently announced that we're awarded. And we have collaboration with others, including USC. And Caris Life Sciences is a commercial company that does a lot of the sequencing. We're developing collaborations with them to not only do genetic testing on patients' tumors, but also help develop new technologies and get the information to look and track outcomes. So the slide here, changed the font on loading it, sorry. But some of the things that we're doing right now, pharmacogenetics, we use genetics to predict the use of drugs, the metabolism of drugs, drug interactions, drug toxicity. Infrastructure to do all this genetic testing, which we'll get into. Mention the high-risk program and just highlight just briefly one. And then my particular interest is rare cancers, and particularly endocrine tumors. But rare cancers are rare, we think, for a reason, that they have some unusual genetic variants. So there is an established genetic counseling service within the Cancer Center, and they do see non-cancer patients. But they consult and refer patients. There are laws that we know about in terms of in order to protect patients' genetic identity and not allow discrimination based on their genetics from either health insurers or employers and things like that. So there are implications in terms of the knowledge that's gained from genetic testing. So meeting with a genetic counselor prior to the testing, and also to help select what is the proper testing. Insurance will pay for some of it, not always. Often they don't. It depends on the indications for the genetic testing. But there is clear guidelines, particularly, for example, BRCA1 and 2 are one of the ones that insurance usually does pay for. But we also know that, for example, germline testing, BRCA is a risk factor in prostate cancer as well. So about 9% of patients that have advanced prostate cancer have an unknown germline mutation in BRCA1. That's the same one as breast and ovarian cancer that Angelina Jolie kind of made famous, if you want, for want of a better term. Lynch-related tumors are tumors like the hereditary non-polyposis cancer syndromes, endometrial cancer. So these are, again, patients' families, members can be at increased risk. There's our indication for earlier screening, colonoscopy, the like. So germline testing, again, in the rare cancers we mentioned, and the high-risk screening programs, as I already alluded to. We have a project starting here based on pharmacogenetics, and this is a study of how patients' genes affect their ability and the response to drugs and the metabolism of drugs. And also, we know that adverse drug reactions make up a significant cause of patients' hospitalizations and even deaths. So as we get older and have cancer, their polypharmacy or multiple drug use increases, and that, again, layers on top of the genetic background of the patient, so it can increase the risks. And so if we can predict either a drug might not work or it could be more toxic, we can pick a different drug or alter the dose. So we're going to do a trial here at the Cancer Center with 50 patients, working with a company called Genelex, and screen these patients. And there's 22 genes that we actually look at. And these are genes that the FDA has associated with drug interactions in the warning labels of the drugs. And we get the clinical and pharmacy history for the patients and analyze that with the genetic background of the patient. And our hypothesis is if we look at the cancer patients where we know polypharmacy is an issue, that at least 30% of those patients will be taking a drug for which there is a cautionary pharmacogenetic variant. Secondary aims, we want to show that it's feasible to do that in the Cancer Center and identify how we might integrate that more broadly into the Hoag community. So not just cancer, but other clinics as well. Let's see here. All right, so yeah, okay, so another goal that we have is to expand the role of genetic counseling and genetic testing in the Cancer Center. So we're working to make that more available. We can test for single genes. So for example, if you have multiple endocrine neoplasia type 2, a rare genetic syndrome with endocrine tumors, you have a RET gene. Now, there are different mutations that occur within RET, but you have a 50-50 chance, because it's autosomal dominant, of inheriting it to your parent or passing it on to your kids if you're affected. Once we know that is, we can be very specific in testing for just that particular mutation. We don't have to test the whole gene. We can just test for a single predisposition mutation. We have panels. So they're like a breast cancer panel, for example. Somebody has a family history of breast cancer, but we don't know which particular mutation, if any, is to blame, if you will, that we can then have a survey of the genes that are involved. And then we also are working to have available what's called whole genome sequencing. Obviously a bigger effort, but we can sequence the entire genome. But that also that tells us more than just cancer genes. In that whole genome, we would know about pharmacy genes, or the pharmacogenetics. We know about predisposition to other diseases, for example, Alzheimer's perhaps. And then also we know about the patient's immunologic background because we get their HLA typing and things like that as part of it. We are working with different partners, including industry and philanthropy, to help offset the cost of certain studies that we're trying to do using genetics as well. I think I eliminated the slide. I'm sorry, I think I eliminated the slide. One of the reasons we're able to do this, I just want to point out, is that the cost has come down. I mean, the Human Genome Project was, $1 billion. We can sequence a whole genome now for roughly $1,000. These panels are in the hundreds of dollars now. I mean, so the cost has come down significantly. That's one of the reasons now that we can apply it. Obviously, it would not be practical to spend $1 billion on every patient with cancer to sequence their genes. As the cost comes down, we can employ the technology. We're working with the one company we're working with, Caris, does what we call a tumor profiling. They look at a panel of roughly 600 genes that are known to be related to cancer and the effect of drugs on cancer, chemotherapy drugs. The RNA in certain cases, where they're informative as well, and certain proteins by immunohistochemistry. And by using this multi-platform profiling the tumor, can often come up with recommendations for drugs that are more likely to work, or also drugs that are less likely to work because of the background. So Caris is also working, well, this is a sample of this report, sorry. So working with Caris, they have these biomarkers we'll call that are either RNA or protein or DNA, and they'll give you a report that lists the mutations. Okay, for example, this one here is ALK in lung cancer. I'm going to get around here. ALK is a gene that is mutated in about 4% of lung cancers. If you have it, though, you will do better on a drug that specifically targets ALK than on standard chemotherapy with less toxicity. Better survival, less toxicity. So if you have lung cancer, you kind of hope that you have, you're one of the 4% that has an ALK fusion or mutation. Similarly, they look at like PD-L1. I've heard about the immune modifier drugs. There are drugs now that help. Well, cancer cells have in their background or the ability to evade the immune system. These drugs are designed to try to take away that cancer's ability and make the patient's own immune system recognize and fight the tumor. And these drugs are available. They've been shown to have efficacy in many tumors, and the PD-L1 is one of the markers that suggests that that would be a good approach in that patient's tumor. So they'll report on PD-L1. But that's it. And down here then you see there's drugs that have potential benefit, what they'll say uncertain benefit or potential lack of benefit. And so we use that to help make treatment decisions. So we're doing this now for all advanced lung cancers beyond stage 1A, basically 1B and above. They're all getting tested at Hoag. Brain cancers, recurrent gynecologic tumors, intermediate and high-grade sarcomas that have been resected, and all head and neck tumors, or if the physician requests it. So this is now standard in our cancer protocols. We are also working, because of our relationship with this vendor, Caris, to gather data and share it with other, what they call centers of excellence, so that we can gather the outcomes data and know that treatments we're doing are helping. So if a doctor says, well, this gene had an NF1 gene mutation, for argument's sake, and we want to see how many patients were treated with what's called PI3 kinase inhibitor in that background. So we say, well, we look at that list, and because we've been gathering the data, we may be able then to see, well, 3 out of 7 patients responded favorably. That's the goal, so that we can then interrogate and find out how action upon these mutations with the recommended drugs, whether it worked or not. We are also have now early access to their newer tests that are in development. We're one of the first sites to get this androgen V7, or a splice variant of the androgen receptor that I'll show you in a second on a slide, is very important in terms of prostate cancer. And, we're working with them to get samples for detecting tumor DNA circulating in the blood. It's much easier to take a blood test to look for tumor DNA in patients that you're following with cancer than to repeat a lung biopsy, for argument's sake. So easier to look at the DNA that way. And I've already talked about having the data available, but we're also trying to, on individual patients, integrate the data, whether it's the X-ray, the molecular test, the lab test, the treatment data, all in one place, so that we can, it's easier to treat the patient, but also when we go to present at tumor boards, we can have the information organized for us to, again, learn better what we're doing. I mentioned just now the androgen receptor splice variant. This paper was a couple years ago, recent, but look, and it's pretty well recognized now that if you have this variant of the androgen receptor in your prostate tumors, you don't respond well to drugs that lower testosterone, or we call it androgen deprivation therapy. enzalutamide, for example. If you have the V7, this is called a waterfall plot. Each bar is a patient. If the bar is going up, it means the PSA is going up. If the bar is down, the PSA is going down. Well, if you have the splice variant and you're on the androgen deprivation therapy, your PSA is going up, which is a surrogate marker for the status of the tumor, right? So you can see that it's pretty well stratifies out, not 100%, but pretty well, that if you have the splice variant, androgen deprivation therapy is probably not as good an option. So the studies now show that you do better with stage 4 prostate cancer on chemotherapy than androgen deprivation therapy. So this is now, just now, within the last couple months, available as a routine for every advanced prostate cancer that gets the Caris profile at Hoag. I mentioned only this slide, which is busy, but I'm just going to say, in addition to looking for the ARV7 variant, we can look at circulating tumor DNA. So if you have the splice variant and circulating tumor DNA, again, you would tend to do worse. So that's the bottom line on that slide. So putting these technologies together can be informative. So the circulating tumor DNA a little bit can be used for a couple different things. One is early detection of recurrence, because instead of doing your CAT scans every 3 to 6 months and monitoring patients for recurrence of cancer, you can do a blood test, and if you start picking up tumor DNA, image the patient. So that's the paradigm, or what the theory is how it can help, is because again, it's a little easier to get a blood test, for example, than a PET scan. Also, for people that have been on treatment, I mentioned lung cancer, and if you use, a lot of the lung cancers have EGFR amplifications, and if you're treated with a drug that targets that, it can eventually be, the tumor can become resistant. It's because it develops a secondary mutation. So you can pick up that mutation in the EGFR receptor in the blood and switch to a next generation EGFR inhibitor, and then the patient can continue to do well. So it's a way of picking up the emergence of that resistance gene, if you will, and then you can switch treatment. Again, mentioned the blood's easier and less expensive than scans and the like, or biopsy. But the other thing it does is we think when you biopsy like one tumor, that's just that one tumor. Getting the blood can be sort of a survey of all the metastases, because they may not all be the same. There can be what we call clonal diversity. The genes, kind of as tumors go, as a branch of a tree, the root mutations might be the same, but as you get out into the branches, this tumor over here has acquired some mutation, this one over here acquired a different one. So you can kind of get more of a survey view by the circulating tumor DNA. It has not proven to be good for screening, for example. Getting a blood test to look for KRAS mutation is not telling you that patient has a colon cancer, but I also don't know where to look, because prostate cancer, or not prostate, pancreas cancer, certain lung cancers, thyroid cancers can all have RAS mutations. So hasn't gone there for screening yet. And so it's just anticipating that question, I guess. But one of the other things is try to take advantage of the genomics to bring in some trials that are targeted specifically to at least the cancers I'm particularly interested in, and taking advantage of the genomics to tailor these treatments. So the International Thyroid Oncology group is a group that I belonged to for a while, and so I moved here. We got Hoag to join as well. And the people that are in there are a lot of the academic institutions. In fact, I think almost all of them are, except, so it's like Johns Hopkins, Mayo Clinic, Memorial Sloan Kettering, Harvard are all members of this group, Ohio State. But it was really led through a patient's effort whose wife was dying of thyroid cancer. And he said, well, how come there's no new drugs and there's nobody doing studies in thyroid cancer? They were looking for investigational agents. So really through his efforts and the efforts of the doctors and the treating team for his wife, they kind of pulled people together, and we formed this group to really start doing clinical trials and new treatments for thyroid cancer. So the most common mutation, and this is just a landscape again of different mutations in thyroid cancer, is BRAF. By far, roughly around 60% of papillary thyroid cancers have mutations in this particular gene. I mean, there's lots of other ones, but by far the most common. Now what this does is when you have BRAF mutated, it turns the gene on. It's a little bit like you've got a car engine and your foot is stuck on the gas. This gene is always turned on. Okay, it's supposed to go on and off under normal regulation when it's bound to phosphate differently, but it's always on. So so this sets up that every gene downstream is also turned on. So, you know, not only is the car engine revving faster, the wheels are turning faster, and it's just all going downstream. So one of the downstream proteins then that gets activated also is MEK. All right, and I'll bring that in a second. And the ultimate effect of that, or at least one of them relevant to the trial we're talking about, is you get increased growth of tumor and that, but also shuts down the pump that drives radioactive iodine into thyroid cancer cells. So since we treat thyroid cancer with radioactive iodine, we want that pump to work and work as well as it can. So the study just does that. There's a drug called selumetinib. It's AstraZeneca, which I have no relationship with. By the way, no disclosures relevant to this talk. So the selumetinib blocks MEK, which in turn results in increased activity of the iodine pump genes. So this is an example. This is before the selumetinib, and this is after. And you see how much more radioactivity or more radioactive iodine is getting into the tumor. So that's what these slides show. So the protocol really is for the patient that has thyroid cancer, metastatic thyroid cancer, to come in, and it's a pill you take twice a day for 4 weeks, then get your radioactive iodine. Of course, the study wants to say, is there a better outcome? Do we get the better tumor kill, if you will, by doing that? This study should open, Deb, within the month, right? So Deb Fridman's been working really hard to help us get this study open. So it's our research administrator. So this is kind of it. Patients have to have structural disease. In other words, we have to be able to see it on X-ray. And then they can't have had a previous similar type of drug and have not approached their maximum lifetime dose of radioactive iodine, I guess, are the main things. My own particular research interest has been in a rare cancer called adrenocortical cancer, cancer of the adrenal gland. It's about 1 in 1.7 million people, so I don't know, 300-400 people in the United States a year get it, something like that. But it tends to affect young adults and slightly more common in women than men. But most people that present already have metastases, and the 5-year survival rate with people that present with stage 4 disease is only 7%. So young people, bad tumor, and the only standard chemotherapy was reported in an article in 2012, which is a combination chemotherapy. But beyond that, there's no standard treatment. There's no second-line treatment that's been effective. So, and the response rate, as I said, is 3%. So what do we do for those other 3/4 of the patients, that don't respond? So this is where we hope genetics can help us. We can't do the traditional trials of we're going to test 500 patients with drug A, 500 patients with drug B, and see who does better, and then we'll go on to the next trial. We can't do that in rare cancers. So we have to, try to be smarter, use what's available to us. So characterization of the genetics of the tumor is very important. So certain things we know are common. P53 mutations, about 20% of the tumor. Beta-catenin pathway, about 40% of the tumor. But we can also predict aggressiveness of the tumor based on some of the genetic profiles that have been identified. And this was all done through a cooperative effort led through the NIH, which they called the Cancer Genome Atlas. They did lots of tumors, but they did the landscape of mutations of lots of tumors. And this was 91 adrenocortical cancers were sequenced with different platforms. We used the molecular profiling or the tumor profiling data to help guide therapy. Right, so if EDPM, the standard chemotherapy regimen, doesn't work. What do we pick next? Clinical trials or something off the shelf based on the patient's tumor profiling is kind of where we are now. And we're in the lab, however, at TGen had a lab where we would test new agents in cell lines and mice. In fact, we've got a project going now testing a new drug in mice that have implanted tumors in their side to see if this new drug works against that. But that can translate into clinical trials. I want to give you an example of that. So we know that adrenal cancers have a signature, their genetic signature shows that the cell cycle that regulates division of cells is perturbed. A lot of cancer cells are. In this cancer, it's at the G2M checkpoint. So that's one of the checkpoints in the cell cycle where the cell says, everything's good, you can keep dividing. Well, in this case, it keeps dividing even though everything isn't good. So we see that P53 is mutated in 53% of the tumor. NF1 is 1 in 17%. There's a gene called PLK1, which is also overactive or overexpressed in a lot of these cancers. And I'll explain that in a second because that's relevant to where we are. So this is a patient's tumor that went on a drug. In our lab, we said targeting that PLK. Now, just a background. PLK is a drug that, or is a gene that affects P53. P53 is like the brake system in a car's engine. I talked about how cancer cells, it's like the foot stuck on the gas and they keep dividing. Well, there are genes that are also supposed to tell cells to stop dividing and to die when they're old or they're supposed to die. Well, that's like the master cylinder in the car's brake system. You can disable that and cancer cells can keep growing. So if you inactivate a tumor suppressor, you get the effect of the tumor continuing to grow. Well, that's what increasing PLK1 does. It suppresses P53, which is the major tumor suppressor. So we're inactivating the suppressor, if you will. So we know that's high from our research in a lot of adrenal cancers. So we had a company come through that had a PLK1 inhibitor, and we said, they wanted us to do a study in carcinoid because during development they had a patient that responded. We said, well, you have to do adrenal cancer. So they agreed to let us treat a few patients. And this was one patient whose tumor shrank on it, significantly. Let's see if we got his story. And PLK1 is active when it's phosphorylated. This brown is all the phosphorylation in the pre-op sample. This is after we resected the residual tumor mass, that the brown is a lot less. We've knocked down the phosphorylation of that tumor. This is the patient. This is the manuscript that we wrote before that took us to the company that said, we want to test your PLK1 inhibitor. This is the gentleman, and he sent me the picture and said, use it any way you want, Doc, but including, because I told him I wanted to show it at a meeting. He came into the office because he had had surgery at the University of Arizona in Tucson. I was up in Phoenix at the time, and he had a recurrence, a tumor in the abdomen. They operated on him, did a colostomy at the time. There was still tumor, came back. He went on chemotherapy. Standard chemotherapy didn't work. And he came in basically in a wheelchair, saying, is there anything you can do for me? So we put him on this agent. All his tumors went away except for that one mass below the kidney that I kind of showed had shrunk. I said, well, I'd like to go in and take that out. And, we'll sequence that too, but I'd like to take it out and we'll take down your colostomy while we're in there because that's the only bit of tumor left. His doc, that's great. I'd like to do it. But remind you, this is a guy who came in the wheelchair. He says, I'm kind of busy right now. I'm coaching my daughter's volleyball. Well, these are his two daughters in their volleyball outfits, so that's the context for the picture. So he sent me, this is him now, a year and a half later, off of treatment with no evidence of recurrence. So this is a great success story. We did go in and resect the tumor. We showed how the drug had been working and had efficacy, but he continues to do well. So combined with our research lab stuff and this story, we've talked to a company that's based out in San Diego, and we've met with them like 3 times. We're going to do a trial with a different but PLK1 inhibitor. here at Hoag will be the lead institution, probably open it at Mayo Clinic, and we're talking to Columbia as well. So 3 sites around the country, kind of divide up the country in thirds so that patients can get drug and we can get the patients on study. But all because of that, but this is all because of the infrastructure that was set up here, get the research and what's going on at Hoag that we can get some of these new treatments. This will bring lots of patients to us that wouldn't have come otherwise, and hopefully we can help them. And we're working on convincing some of our partners to do the sequencing and stuff so we can, again, why did the drug work or why didn't it work? Maybe we can learn something by having the tumor sequence. So the future plans are to continue that paradigm around rare tumors. You know, I mean, in aggregate, rare cancers aren't rare. I mean, you know, cancer of the toe might be rare, but if you start together, pull all the rare cancers together, it's roughly, 20% of all cancers are defined as rare. We think they're rare because they do have unusual or rare genomic aberrations, but that can also expose a vulnerability of the tumor that we can target that. We have the technologies to do these assessments, but said patients get very proactive when they've got rare cancers, and Dr. Google says you got to go to Hoag to get treatment, and they'll get on a plane and come to Hoag. So that's an opportunity for us to grow our cancer programs around that because we've built the infrastructure. So the goal is, and I put asterisks because these are just tentative price points and things like that, but the point of the slide is we want to develop a framework or a consistent menu of offerings that we can have available to the patients in our community and the doctors taking care of those patients, where we can do the pharmacogenetic testing. This is pretty much the price point that we're getting from Genelex. The panels and things, we're still working on those. And so this is the mega sequencing, if you will. The Caris panel, they tell us that the patients won't, even though they bill insurance, the out-of-pocket to the patient won't be more than $550. The insurance is not paying for the whole genome sequencing of the tumor and the RNA yet. So I call the sequencing on steroids or the full Monty. It's the best technology we have right now, but it's roughly in that $3,500 price point, which is a lot less than it used to be. So even a couple years ago, we were doing it at TGen, it was over $10,000. So the price has come down, becomes reasonable in the right patients to use that technology. So we also want a framework that's consistent, so when a doctor or a donor or somebody says, hey, we would like to do something or support something in cancer of the liver, for example, we would like to, it would enroll sequencing, we can tell them what it would cost to do that because we have the infrastructure set up. So it's part of the background of the infrastructure that's very important to have in the cancer center. So that's it, and I guess we have a few minutes for questions. Okay. Sir.
I have a couple of questions.
Oh, okay.
The patient that responded so well but did not respond just at one location below the kidney, any thought process why he did not respond?
Well, he had multiple tumors, and they all went away except for one tiny mass, less than a centimeter, residual behind the left renal vein, and that mass on the inferior pole of the kidney would shrink. The mass, when I got in there to operate on him, I removed the mass by the kidney, but it was mostly fibrosis. There were a few dead cancer cells in it, but it was mostly dead cancer and fibrosis. So I think there was just a residual mass. It wasn't going to go away. It was mostly scar tissue at that point. I couldn't get to, he had had radiation in that area. I didn't want to lose the kidney, so I didn't go after the little mass behind the renal vein. Later, we cyber-knifed that. All the other tumors went away.
So it wasn't because that there was a decreased blood flow to that area?
No, I don't think so. We showed that the phospho-PLK went to D-phosphate or non-phosphated PLK, which is the inactive, went from the active to inactive based on the pre- and post-op immunohistochemistry. So I really think there was on-target effect of the drug.
And my other question was on the polycystic kidney disease. If we have patients with polycystic kidney disease, can we send that to you to do their genomes?
I think the genetic counselors will see those patients, for instance. Yeah. So yeah, we send them through our genetic counselors here in the cancer center, for sure. Well, probably someone's going to win the Nobel Prize for CRISPR. It's a very I think you mean CAR T, or there's two. So CRISPR Cas9 is a way of very accurately, easily editing genes in very specific places. It's used in research. There is some concern that it's going to get used in, like, potentially for good, but also abused for things like edit out the single point mutation in hemophilia, or or sickle cell. So in patients, I don't know that that's been done. People are worried about perversion of these technologies, but I mean, the thought is you can edit. That's what the CRISPR does, allows you to edit genes, very precisely. CAR T is really interesting in that it is genetically re-engineering the immune cells, the T cell receptor, to recognize different antigens. So what they do is they take the cells out, the patient's own white cells out, basically re-engineer the white cells to recognize a tumor antigen, and then grow it up in large number and give it back to the patients. This has resulted in like pediatric leukemia in cures. It's also resulted in some deaths from what they call cytokine release. The patients get massive release of cytokines, and they now have got some better treatments for that. But these were uniformly fatal leukemias, and now they've got survivors and durable survivors with this CAR T technology. The treatment for a single course of CAR T is touted as costing $475,000. So Novartis isn't mad at anybody. That's their process, but it's going to be, it's potential. People are looking at it for treating solid tumors based on tumor antigens. Right now, it's been on certain leukemias, liquid tumors. And it's going to probably only be done in a few specialized centers because of the potential risk and toxicity. So, I don't know. Yes, sir?
You mentioned San Diego. There's a company in San Diego called Illumina.
Right.
Which does something like this. Is there a difference?
Yeah, so what Illumina does is make the machines that do the sequencing. I think they may do some germline testing itself. The company that does, I said, the full Monty, they're across the street from Illumina and use Illumina machines. Illumina's main business is to make the machines that you do the sequencing on. So they're the equipment. We use them at TGen as long as other platforms, but they're the dominant maker of the machines, if you will, that do the sequencing. All right, thank you very much. Appreciate your attention.